Hey, this is Dr. Kusuma. Just wanted to thank everybody for attending our webinar today. We can go ahead and get started. Hopefully, people weren't having any computer issues. So I'm one of the spine surgeons at Bone and Joint Physicians. Today our talk is going to be on spine health, most notably back pain. And so what are the goals for today's talk? So today we're going to be talking about a few main questions. My talk may be technical at times, but I'm really trying to get to the heart of the first two questions. What is wrong, and how can I get better? And then, what should I expect from the doctor when you see the doctor at a doctor's appointment? There will also be a question and answer at the end of the talk, and I believe you can type in questions throughout the webinar. And I'll be happy to answer the questions at the end of the webinar. So today I'm going to just talk about the technical causes of neck and back pain. And to do that, we'll talk about the anatomy of the spine, different causes. We'll talk about diagnosis and then treatment plans. It includes prevention, non-operative treatment, when to seek urgent medical attention, and then assessing the need for surgical intervention. This is not going to be an exhaustive list of all the possible diagnoses. The main goal is mainly to arm you with knowledge so that you can get better no matter what doctor's office you go to. So the anatomy of the spine itself is made up of four main components. The cervical spine is at the top part, that's the neck portion. The thoracic spine is connected to the ribs and surrounds your lungs. It's relatively immobile. Lumbar spine, which is the lower back, is what we'll be talking about today. It's a very fluid portion of the spine and actually bears most of the load in the spine because it's at the bottom. And the coccyx is sort of your tailbone. It's some fused section of the spine. So today we'll mainly be talking about the lumbar portion of the spine, which is a cause for much of patients' back problems. If you do a close-up view of the spine, this is once again a side view. You see these square-like structures are the bones or the vertebral bodies. It's another bone there. In between, you have intervertebral disc. They sort of act as a shock absorbers for your spine. Spinal cord runs right behind these bones, and you can see these nerves come out right behind these discs. And then in the back of the spine, you have different joints, spinous processes, and transverse processes. Those sort of all make up the structures in the back of the spine that all your back muscles are connected to. Once again, if you look at a cross section, this is with a patient lying down. This is the back. This is the front. This is sort of a cross section of the disc. The disc is like a jelly donut. It has a thick outer core and a soft jelly center. Kind of see right behind this intervertebral disc, the nerves in the spinal cord run. Sometimes this jelly donut can herniate out and press on that nerves. So this is sort of some of the causes of low back pain that we'll be going over today. Once again, this is not an exhaustive list, but this is just some of the things that we look for. Degenerative changes, I mean a different term for arthritis in the spine, is sort of the most common. They result in spinal stenosis, herniated lumbar discs. Instability is often due to fractures or something called spondylolisthesis, which we'll go over in a little bit. A lot of times the nerves can be compressed or irritated, especially from the disc herniation. Other things are organic or referred pain, which when you see your doctor in a clinic, they'll make sure to rule out with certain history and physical exam findings. These include tumor, infections, a lot of time pain from the pancreas, the gallbladder, and peptic ulcers, kidney stones, ovarian cysts. All those can be felt in the back, and it's something that we don't want to miss. So the most important thing is when to see a doctor immediately. When is something you don't want to wait and think will just go away on its own. That usually is when you have back pain with constitutional symptoms. So that means that not only do you have back pain, you have stuff that's going out throughout your entire body. These include loss of weight, loss of appetite, fever, if you're immunocompromised, if you had a recent TB contact, known cancer, neurological deficit, meaning you have weakness, or you have loss of bowel or bladder control, meaning you start having accidents. Those are things that should prompt you to see a doctor immediately. So in medical school, the way we were taught is we'd go over certain sample patients, and then we'd talk about how to evaluate them and what steps to do next. So I figured that would be a good way to sort of talk about how I evaluate patients and what to look for when patients come in with certain symptoms. So in this first case, it's a 52-year-old man who has low back pain for one day after shoveling snow. So on exam, I see he has pain with range of motion, he has firm paraspinal muscles with palpation, and he's otherwise normal. What should we do next? So basically, they want to know what's our diagnosis and what else should we order? Should we take him back to surgery urgently, or should we sort of slow play and watch this? Usually these are related to muscle and ligament strains and sprains. Your back is made up of multiple layers of muscles. This is sort of the outer layer right here. The inner layer has multiple small different muscles, all of which can get sprained or pulled or hurt, especially doing something as strenuous as shoveling snow. And when any of those muscles are pulled or torn, you sort of feel pain all throughout your back. So for something like that, in addition, other causes are postural imbalances when you're leaning forward, if you're not using good form, when you're picking up objects. Other things such as pregnancy, obesity, overweight, incorrect posture. If you look at this picture in the bottom, just leaning forward and keeping the boxes far away from you puts a lot of stress on your lower back. And that can cause compression of your vertebral discs and be a source of your back pain. They did a great study multiple years ago about the impact of posture. If they said standing was at normally 100%, you can see sitting slouched forward almost is 3 times as much pressure on your discs as compared to standing. Lying down obviously relieves a lot of the pressure. Leaning forward, lifting weights all increase the pressure. So those are certain things that you want to make sure to minimize to improve your posture as well as improve the strength and pain in your back. So whenever you strain or sprain something after shoveling snow, the usual treatment is very conservative. Most of the pain is very self-limiting, usually resolved on its own for 4 to 6 weeks. We recommend relative rest, meaning we don't recommend bed rest, but you don't want to go out and shovel more snow or do any other heavy lifting. Most people probably won't want to because their back hurts, and usually that's only for a couple of days. If you don't want to wait for the 4 to 6 weeks to feel better, non-opioid analgesics and acetaminophen, which is Tylenol, can be used to help with some of the pain. NSAIDs, which include Aleve or Motrin, and then muscle relaxants, which can be prescribed by your doctor, can help with some of the spasms. And then manipulation by either chiropractor or physical therapy are also very helpful in relieving the pain in the acute phase. But for the most part, most of this is very self-limiting. Just takes some time to get better. For the next case, it's a 36-year-old guy, has mild back pain after lifting boxes, but this time he also has left leg pain. It's going down the back of the leg all the way down to his foot with numbness and tingling. What's usually the next step after something like this? So something like this is very indicative of a lumbar disc herniation. The disc herniation is the most common cause of back and leg pain. It's multifaceted, meaning it has multiple different causes. It's not just the disc itself. There's usually a combination of sprains and strains in your back from all those muscles or ligaments. And there are a lot of things, both in the spine and not in the spine, that can mimic a herniated lumbar disc. So there's some things that your doctor will evaluate you to make sure that it is actually herniated lumbar disc and not something different. The way they do this is they ask you certain questions. What was the mechanism of injury? Where does it hurt? When did it start hurting? What makes it better? What makes it worse? Does it radiate up your back or does it radiate down your legs? And then they may ask certain questions that may seem kind of weird at the time, but they're just trying to rule out serious medical conditions. Do you have a history of cancer? Any IV drug abuse? These are just all the tools that physicians will use to narrow down the diagnosis and to examine you. So how will the physician examine you? First, they should feel your back, see where your tendon palpation. They may ask you to do a certain movements just to test your strength, make sure nothing's weak, test your sensation. Obviously, they'll check your reflexes with a reflex hammer, and then they'll do certain specialized tests, such as straight leg raise, or they may have you lie on your stomach and lift your leg up. What those do is they put certain pressure on some of the nerves, and if they're aggravated, they produce certain signs. Usual clinical presentation for a patient with a disc herniation is they have sharp radiating pain starting at the back and radiating down their legs. And typically when I walk in the room, patients are sort of pacing around the room because they're very uncomfortable sitting. If you remember that prior picture about the pressure on the nerves, sitting actually aggravates the disc pretty significantly. When the disc is herniated, it can aggravate those nerves. So a lot of patients will be pacing and can't find a very comfortable physician. An unusual form of a disc herniation is something called cauda equina syndrome. That's when the disc herniation is so large it completely blocks off the entire spinal cord. So if you see here, in this case, this is with the patient lying on their stomach. The front's down here, the back is up here. See, this large disc herniation is protruding all the way through the back and pressing the entire spinal cord. When that happens, they have bowel and bladder issues. They have saddle anesthesia, which is sort of anesthesia in the groin area and the inner thighs. Essentially, when you sit on a saddle, all those pieces are numb. Then you also have weakness and numbness in your bilateral legs. Very uncommon, but something that should be recognized promptly. Other times you have difficulty with urinating, and sometimes you'll have impotence. Those are things that your doctor will evaluate for to make sure that that's not something that's going on. Otherwise, the neurological exam should include sort of motor and sensory and reflexes. These are certain specific nerve roots that affect specific muscles and affect specific reflexes. These are nothing you have to memorize, but these are something we all know as physicians by heart. X-rays, radiology. The best way to see a herniated disc is with an MRI. Plain films are good also, just to make sure there are no other broken bones, none of your discs are wearing out, and they're also very easy to get in the clinic. MRIs, if anybody's had an MRI before, is a pretty intensive process. You have to sit still for anywhere from 45 minutes to a few hours. It's an allowed machine, and then there's also a copay affiliated with it. So X-rays are very easy, but the MRI is the best to see the herniated disc. You see here, this is once again a side view of the lower back. These bones, these squares are your bones. The disc is in between. You kind of see here, there's one disc just pouching out right back there. If the patient can get an MRI, a CT scan or a myelogram CT scan, which is a very special kind of CT scan with dye, can be used instead. Initial conservative treatment for herniated disc, assuming it's not cauda equina syndrome, is usually a short period of rest, anti-inflammatory medications, physical therapy, narcotic pain medications, and then other interventional pain management, including epidural steroids. Usually, conservative care is tried for a few months unless the person's neurologic deficits is worsening, meaning should their numbness be getting worse or should they start having motor weakness. The non-operative treatment includes, as you see, epidural injection calms down a lot of the inflammation of the nerve. Basically, we're giving the body time to try to heal this on its own. The body likes to take its time, but a lot of times it's very successful. If it's unsuccessful, meaning that if you continue to have pain despite all these non-operative measures, or you start having worsening neurological deficits, which includes weakness, worsening numbness, then we talk about surgery. In surgery, what we do, we go in, it's called a microdiscectomy. Make a small incision in the back. We slide down the bone, make a small little hole in the bone, push the spine just to the side, and pluck that small piece of herniated disc material out so it's not pressing on that nerve anymore. It's usually outpatient or an overnight stay, and it's usually tried whenever conservative care has failed. Next case is a 38-year-old man, low back pain with lifting and twisting. He has a chronic history of low back pain. He has pain in range of motion, firm paraspinal muscles with palpation. Very similar to our first case, except this time he has a chronic history of low back pain. Now in clinic it's very easy to get x-rays, and so a lot of time x-rays will show us the x-rays may show us a few different things. First off is something called spondylolisthesis. What that is just a malalignment of one vertebrae on top of the other. So if you see here, once again, these are your bones, these are your discs. The discs are very good at taking loads that compress it, but they're not very good at these shearing or sliding loads. And plus, when that happens, when one bone slides in front of the other, that opening where that nerve comes out can get pinched. So not only do you have back pain because this is sliding for in front of the other one, you're also pinching that nerve. The other thing you can see on X-rays are discogenic low back pain. That's when your intervertebral discs are wearing out. So your disc should be nice and plump, but sometimes they can degenerate or wear out sooner than they should. When this happens, you have bone spurs, the disc is compressed. Sometimes those bone spurs can press on that nerve, or when that disc space becomes more narrow, that nerve opening gets smaller as well. A lot of time these patients have previous low back pain. The injury itself may just be the straw that broke the camel's back. They may have had this slip or this discogenic or disc degeneration previously that their body tolerated very well, and they just had this acute flare-up from a certain activity that they were doing. Most often, otherwise, symptoms are usually gradually come on, not necessarily from a specific injury. These have a very wide variation of symptoms. Sometimes it's in the back, sometimes it radiates down the legs, sometimes it can have leg weakness, which is called neurogenic claudication when patients walk. So something we look at, X-rays are very helpful. Physical exam is often nonspecific. Patients have some spasms in the back. Sometimes they'll have tenderness because of the step-off, because of the slip of one bone on top of the other. A lot of times they'll have worsening back pain or leg pain on extension. Usually they don't have a neurological deficit because these are very slow acting, so the nerve can take a lot of pressure when these degenerative conditions occur over time. So you see on the X-ray, we usually get upright films, meaning you notice you get X-rays with patients standing up, not with them lying down. You can kind of see these are the bones here. These are the discs. If you see here, this bone is sliding in front of that disc, in front of the other bone, and actually wearing that disc out. MRI will give a good idea of how much that nerve is being compressed. And if you can't get MRI, sometimes we can get a CT scan as well. So what can you do about something like this? So treatments include medication, very conservative treatment, helps with acute flare-ups, includes anti-inflammatory medications, includes non-narcotic pain medications, occasionally includes muscle relaxers, and even oral steroids to calm some of the inflammation. Narcotic pain medications are good, but we usually recommend them only for a short term. As most people know, the longer you take the narcotics, the less they work, less effective they are, and then also sometimes people become dependent on them. So we try to, they're very good drugs in relieving pain, but we like to use them only for a short period of time to relieve the acute exacerbation. If they go on for a chronic period, antidepressants or antiepileptics are very good at helping with chronic pain. What happens with chronic pain, sometimes they can change the structure of the nerve endings, and so that's why medications such as antidepressants or antiepileptics, although they may have a negative stigma, are very helpful in helping patients with chronic low back pain. Other things we also recommend include physical therapy, includes hot packs, ice packs, ultrasound, range of motion, core strengthening, and sometimes even traction, or our clinic has a VAX-D traction, which is very helpful to relieve some of the tension in your lower back. Other things, chiropractor, massage, inversion table, yoga, tai chi, back braces, neck braces, all things that are in our armamentarium of conservative treatments to help patients with back pain that's not necessarily surgical intervention or even injections. Once again, flexion-based exercises, core strengthening, and then epidural steroid injections. If those don't work, as well as some other interventional pain management, includes radiofrequency ablation and a wide range of modalities of injections that anesthesia or pain management can usually assist us with. Surgical treatment for something like this, for either the discogenic disease or the spondylolisthesis, is a fusion. For the disc herniation, is a fairly simple outpatient procedure where we just take off the herniated portion of the disc. For something like this, it requires something a little bit more aggressive. In this case, because it's unstable, meaning one is sliding on top of the other, we have to make this more stable. And the best way we have to do it right now is really with screws and rods. What that does is it reduces that slip. You kind of see that slip is reduced, and holds it in place. And so reduced slip holds it in place. In this case, they also put a cage in the front, which you can see by those 4 dots right there. What that does is it prevents this from sliding any further, and holds it in place so it doesn't cause any more pain. Case 4, it's a 52-year-old lady, has mild back pain, but really leg cramping when she walks. Unable to walk further. Previously, she was able to walk a few miles, and by the time she sees me, she's only able to walk a few blocks before she has to stop and rest. When she's shopping, however, she can walk much further when she's leaning forward. Physical exam, they don't really find anything. So what should we do next? Now, this is a very classic case of something called spinal stenosis. This patient with this can have a varying combination of low back pain. They can have radicular symptoms, which means pain down the leg, or neurogenic claudication, which is that cramping sensation that she was talking about. A lot of time patients have worsening pain when they lean backwards, and then improving in their pain or improving in their symptom when they lean forward, which is somewhat the opposite of what patients with disc herniations have. Oftentimes, when I see them in clinic, their neurological exam is normal, and patients think that I won't be able to find anything because when they come see me, they aren't hurting too much. On the X-ray, plain films, very easy once again to get in the clinic. Want to make sure that we don't have any of the previous things that we saw, such as the spondylolisthesis or the disc disease. The MRI does a really good job for helping us diagnose the spinal stenosis, however. If you look at the side view, right up here, once again, these blocks are the bones, the disc space is in between. This is what the spinal canal should look like. It should have a lot of space. This white stuff is fluid, so the spinal cord and the nerves are bathing in the spinal fluid, and they have a lot of space. If you look down here, combination of the disc wearing out, a little bit of a slip or a little bit of spondylolisthesis there, it's pinching the nerves right behind it, and so the nerves can't send their signals down to the legs, which is why you have this cramping sensation. If you look at a cross-sectional view, this is the back, this is the front. The spinal canal should be nice and round. In this case, it's very pinched, almost a triangle in shape. That's sort of a hallmark of the spinal stenosis. You should see some of this fluid even in this cross-sectional view, and here you see almost nothing. Treatment for something like this. Conservative treatment we do recommend first. This is not a life-threatening condition, so if we can do something to try to make patients feel better that's non-surgical, we're more than happy to do this. It includes physical therapy, although usually that's of limited benefit. Core strengthening is always important, however. Epidural steroid injections and other interventional pain management do significantly help. A lot of times when those nerves are pinched, giving some localized steroids helps calm a lot of the swelling and allows the nerves to function a little bit better. When those don't work, we discuss surgical treatment. Surgical treatment is decompression with or without a fusion. The main treatment for spinal stenosis is removing the pressure on the nerve. So you take the bone off that's pressing on the nerve. However, if they have the spondylolisthesis, meaning the slippage, when you take this bone off, sometimes the slip can get worse. So in that case, you have to decompress them and you have to fuse them. Or if they have scoliosis, meaning a lateral curvature or side curvature of the spine, if you take that bone off to try to relieve some of the pressure, you can worsen the scoliosis. And so in that case, you want to fuse them at the same time that you do decompression so as to not worsen any underlying disease they may have. So in summary, the spine is very, very complicated. It has a lot of bones, a lot of muscles that are all involved. When there's this many structures in play, any of them can get injured, and when any of those get injured, they hurt. Some of the main causes: lumbar strains and sprains, degenerative conditions such as disc herniations and scoliosis, instability such as fractures and spondylolisthesis, nerve compression, so when the disc herniates back and presses on the nerve as it exits out, and then other organic and referred pain, which we didn't go over too much, but it's something that we do think about to make sure not to miss. And so the number one question everybody asks is, how can I get better? And so this is a wide range of conservative treatments. You see those medications on the left side, in the middle are other exercise that people can do on their own. On the right are sort of other modalities that require some assistance. Inversion table acupuncture require specialized individuals to help with that. And then steroid injections, or the combination of interventional pain management. Not only includes epidural injection, but radiofrequency ablation and other interventions that are aimed to help patients with their back pain. And then things that are very worrisome: should patients have constitutional symptoms, meaning loss of weight, loss of appetite, known cancer, neurological deficits, especially if patients are previously able to walk on their own and within a matter of a few months start needing a walker. That's something very worrisome. Patients shouldn't deteriorate that quickly. Then loss of bowel and bladder control. Patients that are able to control their bowel and bladder all of a sudden start having accidents, whereas before they never did, is something that should be evaluated very urgently. And then cardiac quiet syndrome that we talked about before, when you have saddle anesthesia, motor and sensory deficits in your legs, difficulty urination. It's very uncommon, but something that should be recognized very promptly as well. So thank you for your attention, and I'll be happy to answer any questions that people may have. So one of the questions was, at which offices do we practice? Obviously, our main hospital is Ingalls. That's where we do all our surgeries. However, our clinics are unfortunately not located there. We have one clinic on 111th Street in Oak Lawn. We have another clinic in Orland Park. We have another clinic as well in Calumet City, and then we have one other clinic in the Ingalls Flossmoor building in the Homewood Flossmoor. The specific addresses, if you're interested, is the one in Oak Lawn is at 5540 on West 111th Street. One in Orland Park is on Harlem Avenue at 15255 South Harlem. The one in Flossmoor at the Ingalls Family Care Center on Governor's Highway. The one in Calumet City is at 167th Street. One of the questions was asked is, how much does weight have to do with back pain? So weight has a significant amount to do with back pain. If you look at this picture, I'll go back to the one. So weight, if you notice, when patients are obese, they tend to put a lot more pressure on the discs in the back because they have a lot more weight out front. This patient's holding a box, but patients that are obese essentially are carrying around a box in front of them at all times. And so when patients weigh less, their back muscles aren't strained as much. So obesity has a good bit to do. A lot of times, however, patients, even skinny patients, can still have back pain, but weight does play a very important component. And a lot of patients that are overweight, when they lose weight, a lot of their back pain is resolved. And so that's a very, not easy, but a very useful non-surgical tool that patients can do on their own. Another patient that has a previous spinal fusion is still having pain from nerves in both legs and feet. Now, when you have symptoms like that, a lot of times we need a little bit more information. It's hard to know if the nerves were completely decompressed. As you can see, a lot of times fusion is good for instability, but not necessarily great for relieving the nerves. So I talked about a fusion for the spondylolisthesis and disc disease, but the decompression is for the spinal stenosis. The decompression would actually take the pressure off the nerves. So sometimes the decompression may not have been complete. A lot of times, however, even if the decompression is done, the damage may already be done to the nerves. So if the patients have had severe pain for multiple years and then they finally get the decompression later on, a lot of times the nerves will be damaged and will take a lot longer to recover than having been decompressed earlier. So there is a question about a patient having low back pain for multiple years with a diagnosis of scoliosis. She had physical therapy and managing the pain with core exercises. She can sort of hear her backbones click. Those are the facet joints. And is currently using a muscle relief roll daily. Should I continue managing, or is there a further any other treatment? So for something like scoliosis, the main kind of treatment is a fairly lengthy surgery, which includes surgical fusion. So we have a way to fix it, but if you're able to manage it with core exercises and a rolling brace daily, those are very, very good exercises, and they do make you stronger. But unfortunately, those are something you just have to do every day. There's not a great solution at this time to manage the pain besides a surgical intervention. The patient can often try other interventional pain management, which includes injections or physical therapy. Injections, which includes radio frequency ablation or epidural injections. Injections like that a lot of times will help some of the joints that are feeling abnormal stress from your scoliosis. When the scoliosis curvature is present, there is a abnormal stress on the facet joints more on one side than the other, and so those facet joints get mildly arthritic, and you can hear the clicking when they grind, or sometimes they'll have they'll build up some gas in them, kind of like your knuckles do, and if you want to pop their back to feel better. So the surgical intervention to treat that is to stop the clicking and fix the scoliosis, which would be a fusion. Other interventions are ways to inject local anesthetic and steroids right around the joints themselves to help with some of that pain. What things you're doing sound like great exercises, and the fact that they're strengthening your muscles. You're doing them daily, which is very important. And they're currently being successful. Once those stop being successful, or once the pain gets to the point that those are no longer helping, then you want to talk about doing something a little bit more aggressive, including injections or surgical intervention. Somebody asked, what is the root cause of leg pain when all neurological exams come back normal? So with leg pain, there are a lot of things that can cause leg pain that we didn't go over. A lot of times the nerves can be compressed outside of the spine, which includes some of the muscles in your back, some of the muscles going down your legs. So there's a lot of different types of there are a lot of different ways that the nerves or legs can be compressed. A lot of times there are also vascular issues, meaning your blood vessels aren't working down your leg. I want to make sure that those are ruled out as well, and that it's not just definitely coming from your back. A lot of times the epidural injections can be both diagnostic and therapeutic, meaning that they help relieve the pain. And if you get the injection in your back and that helps your leg pain, then you know it's coming from your back because we've treated the root cause. If you get the injection, there's no change in your leg pain, then a lot of times you have to look elsewhere. And different tests can help with that. Certain tests such as EMGs, which test your nerves throughout your legs, ABIs, or other vascular studies which check the blood vessels, and maybe further imaging such as MRIs of different joints can shed a lot of light on the rest of your legs. Oh, there you go. Is it possible the nerves will come back? In medicine, when we talk about possibilities and probabilities, anything is possible. It is very possible the nerves will come back. Nerve roots, usually in that level, do come back. The nerves in that level are really resilient and are able to come back. Now, this isn't always the case, and usually it does take a few years to come back. Sometimes they have to regrow, and they usually regrow at approximately 1 millimeter a day. So if you think about the full length of your leg, that takes a long time to travel that entire length. So there is always a chance the nerves will come back. A lot of times when they do come back, they're more painful than initially. It's similar to how when patients' legs fall asleep, when they wake up, you feel a tingling and a little bit of sharp pain before you get your entire sensation back. So a lot of times when you have the pain is because the nerves are regenerating and are coming back. So a lot of times when they do come back, it is a little bit more painful than initially. So somebody's asking about myofascial back pain by an X-ray and MRI. I'm not completely sure how patients diagnose or get diagnosed with myofascial back pain. I'm not sure if it's done by a chiropractor or physical therapy. Usually myofascial back pain, what that tends to mean is that you have just chronic strains and sprains in your lower back. If you've done physical therapy, then the sort of the next step would be is injections in different spots. The injections sort of at the level of the disc, at the level of the exiting nerve, in the muscles themselves. Those will help both diagnose the pain, because if you have an injection in the muscles and they help, whereas an injection in the spinal canal itself doesn't help, then you know that the injection in the muscle does help, or that the pathology is in the muscle. So a lot of times the injections help us diagnosing the exact root cause, because a lot of time imaging studies can show multiple different things, but that doesn't necessarily mean that that's one specific problem. It's similar to going to a mechanic for an oil change and they tell you, oh, carburetor's out, your timing belt's off, your brakes are gone, your shocks are out, we need to fix all of that. Well, sure, they may be gone, but that's not what you were there for. You were there specifically for an oil change. The body is very similar. A lot of times if you get an MRI of the entire spine, you'll find all sorts of different pathology, but you're mainly interested in the one specific pathology that's causing your symptoms. And so that's really what you want to treat. So myofascial back pain is a very broad term for muscular and ligamentous injury in the back. Usually you want to get further evaluated to make sure that there's no discs or nerve issues, that there's no spinal stenosis or discs that are wearing out, to make sure that those which can be treated are not the main causes of your pain. Another patient said, what's the most effective for a really stiff spine? Now, I'm a little confused at what stiff spine means. So stiff spine can mean that patient's inflexible. Stiff spine can mean that it's wearing out, meaning their patients are degenerating. And they have more bone spurs as well, and have some arthritis and disc degeneration. Usually the two of those are a little bit different. If the patients are just inflexible, the only real treatment is aggressive physical therapy and aggressive home exercises. Being stiff means that patients tighten up very easily, and so it's something that patients need to work on for a long period of time, not only with formal physical therapy, but with an aggressive home program that patients continue to do. Patients that are stiff that do therapy usually get better. Unfortunately, the hardest part about physical therapy that I tell all my patients is continue doing it even when physical therapy is over. It's very easy when you go to the therapist and they tell you exactly what to do. It's very hard to have to do it on your own. A patient notices they do well when they do it on their own, but when they stop, that's when their pain comes back. And it's much harder to treat than it is to prevent. Preventing it and doing the exercise daily, it is a little bit of a nuisance, but it's very helpful, very painless. But when patients twist their back abnormally or have terrible spasms, it's incredibly painful, and sometimes there's not a lot that we can do besides give it time. If the spine is stiff from disc degeneration, therapy is very good for that, but a lot of times therapy can cause some pain in the back, and so when it hurts to move, patients tend to not want to move and not want to do the exercise. In that case, we talk about the injections or even surgery. A lot of times, even though we fuse them, we're fixing the pain generators, and so patients' movement actually gets a little bit better because their pain goes away. Mind you, their total range of motion is less, but when they were painful, they were only using such a little bit of the range of motion that the total range of motion wasn't being used anyway. when they have surgery and they fix their symptoms, patients actually are able to move a little bit better because they don't hurt as much. And in essence, their symptomatology is improved, their pathology is improved, and therefore they're less stiff. Somebody's asking about chiropractors. That's a very common question I get. I think if you have just degenerative disc disease, or if you have back pain, chronic back pain with findings that are normal elsewhere, I think chiropractors are great. It is true some people swear by them and get results. The main thing I want to do is make sure the chiropractors aren't doing any harm. A lot of times the chiropractors don't test, don't get MRIs, don't get other studies to make sure there's no disc herniation or no pressure on any of the nerves. And if you've ever been to a chiropractor, you know that there's a wide range of different chiropractic manipulations. Some people twist and contort you like a pretzel. Another chiropractors are very gentle and do gentle manipulation. Ones that know the limits and ones that know that to rule out any other pathology are the ones that are very useful. A lot of times the patients come to me and they have mainly axial back pain with imaging that looks fairly okay. Then I'll definitely recommend that they can try a chiropractor. As you know, unfortunately, I see sort of the mishaps of chiropractor, so I am a little biased. If patients have had bad herniated discs that nobody knew about and they get twisted and the disc herniation gets significantly worse, and then they finally come to me, obviously I'm going to have a bad opinion of the chiropractor. The patients that do well never come see me, so I never get to see how well they do. So that is my bias, but I do recommend chiropractic manipulation for back pain without any other existing pathology. Somebody's asking, could the bone graft at the base of the spine cause nerve pain? So whenever we do surgery in the spine to create a fusion, we are expecting the bone to create, we are expecting the spine to create a little bit more bone to allow that part of the spine to become immobile. When we do that, sometimes the bone can encroach on the nerves. Now that would be seen pretty readily on an imaging studies, including MRI or CT scans. And usually the bone doesn't grow that out of hand. So it is possible, but it is fairly unlikely. A lot of the bone we place is usually out of the range of the nerves. As surgeons, at least for me, I know I'm very careful with the nerves, and I'm careful to keep the bone graft away from them to make sure that they're not encroaching upon it. Something as specific as this, it's very hard to give a specific answer because it's a very specific question based on what somebody's gone through. So yes, it is possible. However, it's very unlikely. Once again, we talk about possibilities and probabilities, and the probability that the bone graft at the spine that's trying to help with the fusion is impinging on the nerves is very low. Sometimes if the fusion didn't take, meaning that they had surgery but the spine failed to fuse, that can still cause some nerve pain. Usually, however, that usually causes more back pain than pain down the legs. Okay, well, I appreciate everybody coming to this webinar. If you have any other questions, please feel free to call our office or make an appointment. And thank you once again for your attention.